Hey guys, welcome back to another lecture of Dental Pathshala where we help you understand and learn dentistry better and easy way. And today's lecture is about the express revision course for orthodontics. And before we get started, make sure you subscribe to the channel and click on the bell icon so that you don't miss any of our future interesting videos. And also you don't have to take down notes. You will be provided in the link in the description box below. So you will find the notes to the specific video. Also, if you are looking for more interesting notes, you can find it in www.xtooth.com. So let's get started with the orthodontics. So first of all, this is an express revision course. We are not going to cover each and everything, whatever is required for our competitive exam. So the first thing is our Jackson's triad. So Jackson's triad, as the name suggests, that this is a triad means three things, right? So a triad is composed of three things. So one is, this Jackson's triad is basically based on the aim and the objectives of orthodontics. So when we are talking about the aim and objective of orthodontics, we have got three aims and objectives, three main functions of our orthodontic. So this is a orthodontic triangle also, you can say. So the aims and objectives of orthodontic deals with the functional efficacy, functional efficiency. That means the patient should be able to chew properly after the orthodontic treatment. The aesthetic harmony, as we all know that most of the patients, they seek orthodontic treatment for the purpose of aesthetic. So that means when a person has come to your clinic and if you are doing some orthodontic treatment, then that treatment should fulfill the aesthetic desire of the patient, aesthetic requirements of the patient. Suppose if a patient has come because of the proclined upper teeth or due to the crowding, so that should be fulfilled. Along with that, there should be structural balance. So that means there should not be pain in the TMJ due to the orthodontic treatment and all that. So this is our Jackson's triad, which covers the aims and objective of orthodontic treatment. Now talking about main important thing of the part 1. So this is a part 1 of our orthodontic series. So growth and development. What do you mean by growth? Growth is the self multiplication, which was given by Huxley. There are so many definitions for growth. So growth is basically the self multiplication of a living substance, and development on the other hand means progression towards maturity, which was given by the Todd. Again, there are many definitions for development also. So this is the progress towards maturity. So growth and development, what do we mean by growth? Growth means there is going to be growths, increase in the size, increase in the structure of that particular tissue, and development is toward the maturity. It doesn't mean that it is going to increase in the size and all. So this is the difference between growth and the development. So talking about the secular trends, guys, are the change in the size. So they are the change in the size, or we can say the maturation. So change in the size and the maturation, we are talking about over a large population. So change in the size and maturation over a large population, which occurs over time. So that means these trends means, suppose if there is a fashion trend going on in the society, so this is like kind of population on a large scale, which we are talking about over a period of time. So we are calculating it over a period of time. That means in 1950s this was particular this thing, in 1960s this was the trend. So this is a change in the size and maturation of a large population that occurs over time. So next is the rhythm of the growth. That means growth is not constant and growth is not steady. That means, what do we mean by growth is not steady? This means that suppose a child is growing. So this child, if once he becomes matured, adult, So over this period of time, whenever the growth is happening, so not every time it is like 1 inch per year, the growth is not like that. In 1 year or 2 years, there may be a large, there may be some more growth. Suppose in another year, there may be no or close to zero growth, right? So that is how we define that there is a rhythm of growth. Growth is not constant, growth is not steady. So there is a rhythm of the growth. So we have got 4 rhythms of growth. So 4 rhythms. First rhythm is the first wave, we can say. So first wave of growth is basically the first rhythm, right? So this is the rapid. There is going to be rapid growth, rapid intense growth. And when does it happen? When the child is from first to second year. So the first 2 years of life, we can say, is the main rapid growth, or we can say from birth to 5-6 years of age, a child is going to have a rapid and intense growth. Then comes the second wave of growth. Second wave of growth means now the growth is going to be slow. The growth is not rapid now, the growth is slow. So this is a second slow wave of growth. It usually, this growth ends in boys by the age of 10 to 12 years, and it ends in girls by the age of 10 years. Next, third wave of growth, third rhythm of growth, or the third wave is the accelerated rhythm. So this is the accelerated rhythm. That means sudden rapid growth. So accelerated growth is what we see in the adolescents, and this usually occur by 14 to 16 years. So the fourth wave of growth is the final growth, phase. So after this, growth will be close to negligible, or we can say there is no growth, there is no increase in the size, right? So boys, it is up to 25 years, and girls usually lag behind. So this is 18 to 20 years. Up to 20 years there can be growth in girls, and boys up to 25 years. So these are the 4 rhythms of growth. First wave, which is the rapid, second wave, which is the slow, third wave which is the accelerated, and the fourth one is the final. And how can we remember it? We can remember it RS at phone. So that is my brother's phone. I am going to write F. So that is my brother's name, Ranjit Singh at phone, because he is always on phone. So that is why I have made this mnemonic for you. So Ranjit Singh at phone. So this is R for rapid, S for slow, A for accelerated, and F for final. So these are the rhythms of the growth. So the rhythms of growth is RS Ranjit Singh at phone. So which is RSAF, accelerated, slow, rapid, slow, accelerated, and final. And this period of accelerated growth, we actually call it the growth spurts. So the growth spurts may be due to hormones. These are the period of accelerated growth. So let's talk about the growth spurts. So growth spurts are the period of accelerated growth. That means there is a lot of growth which is happening during this time, and usually this period are not only the adolescent, but so many periods are there. We are going to talk about the growth spurts. So before we know what are the timing of the growth spurts, let's just understand that all the growth modifications procedure. So all the growth modification methods like functional modification methods are done during this growth spurt, because this is the time when the growth is happening. So that means if we want to give functional appliance to a child, this is the best time to give. If we want to give the orthopedic appliance, this is the best time. So also the orthodontic appliances must be given at this time. And if we want to do the surgical correction, suppose in case of class 3, if we want to do by the surgical correction, it should be avoided during this time. Why? Because again growth will happen, because the child is growing, still growing. So all the surgical correction actually should be done after the growth spurts. After the growth spurts. Now let's know what are the growth spurts, what are the timing for the growth spurts. First one is just before the birth. Second is 1 year after birth. Third one we have is the mixed dentition period. So mixed dentition period, which is usually 8 to 12 years. So in boys it is 8 to 11 years, and in girls we know that in the growth girls usually lag behind, 7 to 9 years. And the fourth one we have is the pre-pubertal growth spurts. So this is the pre-pubertal growth spurt, which is usually 11 to 16 years, right? So for boys, pre-pubertal growth spurt will be 14 to 16 years, because boys reach puberty later on compared to the girls where it is 11 to 13 years. So girls attains the puberty first, right? We know that. So this is about the growth spurts. The growth spurts, the first one we have is the birth. The second one we have is the 1 year after birth. And then the third one is the mixed dentition period, which is in the boys 8 to 11 years, in the girls which is 7 to 9 years. Then pre-pubertal growth spurt in the boys which is 14 to 16 years, and in the girls which is 11 to 13 years. So these are the growth spurts. Now let's understand few terms such as the velocity curve. What do we mean by the velocity curve? Velocity curve is the rate of gain of height over a period of time. So a velocity curve is the rate of gain of height. That means a child is gaining height over a period of time. Over a period of time is our velocity curve. And it is useful to identify the onset of. So it is useful to identify the onset of the growth spurts, which is the velocity curve. Right. Next term we have is the peak height velocity. So as the name suggests, peak height, that means a child is going to have the maximum increase in the height. So this is the maximum rate of gain of height. Peak means highest. That means the maximum rate of gain of height. Rate of gain of height is our peak height velocity, and it is an excellent indicator of overall growth. So it is an excellent indicator of overall growth. Now this growth can be somatic and the skeletal growth, right? So it is basically a good indicator of the facial growth. And sesamoid is attained during this period, right? So this is about peak height velocity. Now that we understand the peak height velocity, now we can go through the duration of adolescent. So the duration of the adolescence. So the duration of adolescent growth are different for boys and girls, and we have got 4 stages. So this side we are going to write boys, and here is the girls. Now the stage 1, which is the beginning of the adolescent stage. So beginning of the adolescent growth. In the boys we are going to see fat spurts. So in the boys, fat spurts, weight gain, feminine fat distribution, and in the girls we are going to see the first appearance of breast buds and initial pubic hair growth. Initial pubic hair. Now talking about the stage 2, which is about 12 months later to the stage 1. So about 12 months later we have got stage 2. So stage 2, first of all, in the girls it is the peak velocity of height. So peak velocity of height is seen at the stage 2 for girls, and for boys it is going to be height spurt beginning. So the height now in the boys begins, height spurt beginning, and also there is a reduction in the fat, feminine fat distribution is reduced, and there is pubic hair growth which is seen. In the girls, on the other hand, we see that there is noticeable breast development. Now the breast buds which were in stage 1, they have become now noticeable. So there is a noticeable breast development. Also we see axillary growth, axillary hair, and more abundant pubic hair. Pubic hair we see now abundant. So talking about stage 3, which is in the boys 8 to 12 months later, but in the girls which is 12 to 18 months later. So in the boys it is peak velocity of height. The stage 3 is the peak velocity of height for the boys, and stage 2 is the peak velocity of height for the girls, as we can see. So stage 3 is the peak velocity, which is 8 to 12 months later, is the peak velocity in the height stage 3, which is for boys. And in the girls, the stage 3 is the stage where the growth spurts end. So the growth spurts ends in the stage 3 for girls. Now in the boys, in stage 3 we see that there is going to be facial hair, and especially the upper lip. So we see moustache coming up. Also we see axillary hair in boys, and at the stage 3 also muscular growth. Now the body of boys is becoming more masculine. So in the girls there is an end of the growth spurts, and also beginning of the menses, and broad hips, and breast development is completed in this stage. So breast development is completed. Now stage 4 is the stage only for boys, because as we have seen, the growth spurts end for girls by the stage 3. So stage 4, which is 15 to 24 months later, that is almost 2 years later, the growth spurts end for boys at the stage 4. But for girls we know that the growth spurts is wherein all the height takes place, right? So growth spurts ends, and in the boys we see that facial hair, pubic hair, axillary hair, pubic hair, right? So to summarize it up, the duration of adolescent growth for the boys is from 1 to 4, while on the other hand for girls it is only for stage 1 to 3. So for girls the duration is up to 3.5 years. So as you can see, for girls it is only this much, up to stage 3. So it is the duration of adolescent for girls, it is up to 3.5 years. But for boys it is till stage 4, right? For boys it is stage 1, 2, 3 and 4. The growth spurts end at stage 4 for boys. So that is 5 years. So this is the duration of the adolescent, and few important points in the duration of the adolescent. So that is stage 1 girls, there is a breast bud which is develops, right? So, and of course for boys it is the fat spurts. For stage 2 the peak velocity height is for girls stage 2, peak velocity of height for boys it is stage 3. We know that maturation comes bit later on for boys as compared to the girls. Peak height velocity we have already covered, which is the maximum rate of gain of height, the maximum gain in the height of that individual. For girls it comes earlier, for boys it is later on in the life at the stage 3. So stage 3 is basically for boys is the onset of maturation, while for the girls stage 3 is where the maturation ends, the growth spurts end, right? So for girls the stage 3 is where the growth spurts end, ends, and for boys it is the stage 4 wherein the growth spurts end. So let's move into another topic, which is the timing of the cranial base growth. So at the birth, by birth it is 55 to 60% of the adult size, and by 4 to 7 years it is more than 90%, which is the question which is asked. More than 90% of the growth of brain vault is achieved by 4 to 7 years, which is 94%. So more than 90 it is of the adult size. And 8 to 13 years is the time when the cranial base growth completes by 98% of the adult size. So the important point is by 4 to 7 years more than 90% of the cranial base growth occurs, right? So by 4 to 7 years. So how you can remember it? You can remember it via 4 is there and 4 is here. 8 is here, 8 is here, right? So 4 to 94 and 8 years is 98. You can remember it this way. So next we are going to talk about the growth in general. So let's talk about the percentage. By how many years, what percentage growth occurs where? So the cranium will talk about, maxilla will talk about, and mandible will talk about. And mandible. And by what year? Let's see, 1 to 5 years, then 5 to 10 years, 5 to 10 years, let's use some other color, 5 to 10 years, and 10 to 20 years. So cranium for 1 to 5 years grows by 85%. Maxilla for 1 to 5 years grows only 45%. And mandible 40%, less than that. So as we go, we'll be talking about cephalocaudal growth curve. As we go as we go from head to toe, so there is going to be increase in the growth from head to toe, right? So the postnatally growth is usually away from the brain. So we will talk about it, don't worry. So for 5 to 10 years, 11% cranium. So cranium is going to be decrease in percentage, and maxillite is going to be 20% and mandible 25%. Then we have 10 to 20 years. 10 to 20 years, cranium grows only 4%. As we have talked about cranial vault, after 8 to 13 years, it is 98%. So by 10 to 20 years, it is only 4%. For maxilla, it is 35%, and mandible also same 35%. So this is the growth. By which year? How much growth occurs? How much percentage of the cranium grows? By 1 to 5 years, it is 85, maxilla 45, mandible 40%. 5 to 10 years, cranium 11, maxilla 20, mandible 25. And 10 to 20 years, cranium very less grows because most of the growth is completed by 1 to 5 years. So by 4 to 7 years, we have studied that 94% of the cranium, 94% of the adult size, it reaches by 4 to 7 years. So you can remember 94, right? So next one we have is the differential growth. That means different. Everything is different. Differential growth is when different organ grow at different rates to the different amount. See, I told you everything is different, and at the different times. So we have got different organs grow at different rates to different amount and at different times, and in that we have two curves. One is the Scammons growth curve, and another one we have is the cephalocaudal growth curve. Cephalocaudal growth curve. And my lovely students, Scammon growth curve is so important. So let's first talk about the Scammons growth curve. So Scammons growth curve, there are 4 tissues in this curve. So let's study first the Scammons growth curve. So this is our percentage of the adult size, and y-axis we have the time period. So birth 10 years, then 20 years. So the first tissues, let's talk about the lymphoid tissues. So the lymphoid tissues, basically lymph nodes and all. So lymphoid tissues grow rapidly in the late childhood, and they reaches up to its maximum, that is the 200% of the adult size. This is in order to protect the child from the infection, and by 18 years it undergoes involution. So this is our lymphoid tissues, right? So rapidly in the late childhood, and maximum up to 200% in the late childhood. So next one we have is the neural growth, neural tissues. So the neural tissues are basically our nerves. So the neural tissues, they grow very rapidly and reach maximum by the age of, see, it is growing very rapidly, and reach by the age of 6 to 7 years. And then after this there is very little growth, right? So neural tissues grow very rapidly by 6 to 7 years, and after that there is very little growth. So the third one we have is the general or the visceral tissues. General or the visceral tissues. In this tissues there are bones, muscles, right? Bones and muscles and all. So it is S-shaped curve. It forms a S-shaped curve. Now this S-shaped curve is, that means there is going to be first slow. So there is slow growth, and then first of all there is a rapid growth. First of all I have to change the color, I feel. So first of all there is a rapid growth up to 2 to 3 years. So up to 2 to 3 years there is a rapid growth, and then there is a slow phase from 3 to 10 years. And then after that, after 10 years there is a rapid, or see, we have talked about the general or visceral. You remember Ranjit Singh at phone. So that means first of all there is rapid, then slow, then accelerated, and then accelerated, and then final. That means termination of the growth. So rapid is 2 to 3 years. Then the slow growth is 3 to 10 years. Then after 10 is accelerated. Then final is 18 to 20 years. Very easy. This we have already covered. So this is S shape. Then accelerated. Right. So this is S shape curve. Fourth tissue is going to be our genital tissues. So genital tissues. Genital tissues, there is negligible growth until the puberty. So there is negligible growth until puberty, but after the puberty there is going to be a rapid increase in the growth. So a rapid increase in the pubertal age. So this is the Scammons growth curve. In that we have got the lymphoid tissues in the red color, then we have the neural tissues in the blue color, the purple color we have is the general or visceral, and the green one is the genital tissues. Talking about the next curve we have is the cephalocaudal growth curve. Cephalocaudal growth curve. So what do we mean by cephalocaudal gradient of growth? Cephalocaudal word means head to toe. So there is going to be increase in the growth from head to toe. So if we talk about the postnatal growth, after the birth the growth is away from the hypophysis more. So the length of the head to the body length is going to increase. So the third month of intrauterine life, the head is 50% of the body. At the birth, head is 30% of the body, and adult it is 12% of the body. Right. So there is going to be from head to toe increase in the growth. Now let's study the method of studying growth. So what are the methods of studying growth? Methods of study. How can we study growth? Via two ways. One can be the measurement and another can be experiment. So we can measure the growth, measurement. So the measurement we have got craniometry. Craniometry is basically the first approach which was used to study the growth, and it is based on, as the name suggests, cranio means cranium, metry means going to measure. So craniometry is based on the measurement of the skull. Another method we have is the anthropometry. anthropometry. It is also the measurement of skull, but it is on the living tissues. So using the soft tissues points over the bony landmark. Then we have got cephalometry. Cephs, which we use. Cephalometries, which was given by Broadband in 1931. Then we have got CBCT and CT scan. Cone beam computed tomography and CT scan. So all the 3Ds CT scans. One method is the measurement. The another method is the experiment. We can measure growth via experiments. So it can be a vital staining. It can be a vital staining. Vital stains which we use to measure the growth are, these stains are based on the pattern of the bone growth. So we can remember VITAL. So VI means vital stains, and T we have tetracycline. A we have got 2, basically alizarin. Alizarin, red and blue. So alizarin red and acid alizarin blue and lead acetate. So you can remember it, acetate. So you can remember it, vital stains from VITAL. Then the another, in the experimental, another method we have is the radioisotopes. So radioisotopes. Isotopes. In the radioisotopes, we have technetium 33, calcium 45 and potassium 32. The third one in the measurements is the implants. Third one is we can measure the growth via the implants, and it was introduced by Bajorg in 1969. So these are the methods of studying growth. The measurement, craniometry is the first approach of studying the growth. Then is the anthropometry, which is on the measure the skull dimensions on the live people. Then the cephalometries, which are the Ceph, so which was given by Hoffarth and Broadband in 1931. Then we have the 3 dimensions like CBCT and CT scan. The experimental method of measuring the growth, we can basically measure via vital staining, which is measuring the pattern of the bone growth via vital, VITAL. VI is the vital stain, T is the tetracycline, then A is the alizarin, and L for lead acetate. Radioisotopes, technetium 33, calcium 45, and we have potassium 32, and the another method is the implant. Okay, now talking about hand wrist radiographs, there are many methods of hand wrist radiographs, but we are going to talk about Singer's method, which is important for us for MCQ's point of view. So Singer's method, we will be talking about pisiform, hook of hamate, and second finger proximal phalanx. So the stage 1, which is the early stage, so in that there is absence of pisiform, which is not present. Also there is absence of hook of hamate. So hook of hamate is also not present, and second finger, the proximal phalanx, epiphysis is narrower than the diaphysis. Now talking about the stage 2, which is the prepubertal stage. So stage 2 is the prepubertal stage. In that there is initial ossification. So there is initial ossification of hook of hamate. Hook of hamate. Now in the first stage there was absence of hook of hamate, but in the stage 2 there is initial ossification of the hook of hamate. Also we see that there is initial ossification of the pisiform. In the stage 1 pisiform was absent, but in the stage 2 there is initial ossification. And the second finger, proximal phalanx. Proximal phalanx, the epiphysis is now equal to, in the prepubertal stage, epiphysis is equal to the diaphysis of the proximal phalanx of second finger. Right. So prepubertal stage is prior to the onset of adolescent growth spurts, because this is pre-puberty. So this is before the puberty, prior to the puberty, and prior to the onset of the adolescent growth spurt. So any growth modification procedure can be done during this period. Growth modifications procedures. Right. Can be done during this period. Now coming to the third one we have is the pubertal onset. See, this is not still puberty, it is the onset of the puberty. Fourth stage when we are talking about, that is the pubertal stage. So the third one is the pubertal onset. So this is just the onset of the puberty. So there is beginning of the puberty. So I am writing beginning of the calcification of the ulnar sesamoid. And also we will be talking about the hook of hamate and pisiform now. So there is increase in the calcification. In the stage 2 we have talked about that there is initial ossification. Now the bone is starting to calcify. So initial calcification of the hook of hamate and initial increase in the calcification of the hook of hamate, and also there is increase in the calcification of pisiform. And now what happens in the proximal phalanx of the second finger? Proximal phalanx, there is increase in the width of epiphysis. Right, so this is the pubertal onset. Now we will be talking about the pubertal stage. So stage 4 is the pubertal stage. Pubertal stage. There is calcified ulnar sesamoid. And from pubertal stage we will be talking about the third finger. Till now we were talking about second finger, proximal phalanx, right? Now we will be talking about the middle phalanx. So middle phalanx, the capping of diaphysis by the epiphysis. By the epiphysis. Now the fifth stage we have is the fifth one is the pubertal declaration stage. So there is calcified ulnar sesamoid, yet in the stage 4 pubertal stage also there was calcified ulnar sesamoid. And third finger, middle phalanx, remember third finger, middle phalanx, which we talked about in the pubertal stage. In the pubertal declaration stage we will be going more distally. So distal phalanx, there is fusion of epiphysis with a shaft, with its shaft, and epiphysis of radius and ulna, radius and ulna are not fully fused, not fused fully with this respective shaft. And the sixth stage finally is the growth completion stage. So there is no remaining site which is seen. So growth completion. So these are the hand wrist radiograph Singer method. Stage 1 we have talked about absence of pisiform, absence of hook of hamate, and also second finger proximal phalanx epiphysis is narrower than diaphysis. Prepubertal is before the puberty, so prior to the onset of the adolescent growth spurt we are talking about. So prior to the onset of adolescent growth spurt, prior to the puberty is the prepubertal. So pre means before, pubertal means puberty. So there is initial ossification. So pre word is there. Remember initial ossification of the hook of hamate and pisiform, and also the proximal phalanx of the second finger epiphysis is equal to diaphysis. Talking about pubertal growth spurt, there is beginning pubertal onset. This is onset. So we will start from the beginning of the calcification ulnar sesamoid, beginning of the calcification of ulnar sesamoid, also increase in the calcification of hook of hamate and increase in the calcification of the pisiform, and second finger there is increase in the width of the epiphysis which we see. Now the fourth one we have is the pubertal growth spurt, and that calcified ulnar sesamoid. Third finger we will be talking about middle phalanx and the capping of the diaphysis by the epiphysis. Now fifth one is the pubertal declaration in that calcified ulnar sesamoid. Third finger now distal pharynx. We will be going from the tip of the finger we are going more distally. So proximal, then middle, then distal. Right, then distal phalanx, fusion of the epiphysis with the shaft, and epiphysis of the radius and ulna not fully fused with their respective shafts. And sixth one is the growth completion, where there is no remaining side which is seen. Now guys, talking about the theories of growth, we have theories of growth. So first one we have is the genetic theory, according to which growth is controlled by the genetic factors, genetic influence, and it is pre-planned. So a person's genetic decide, like if the mom and dad are tall, then the child is going to be tall. So according to this, the genetic decides the growth of a person. Then second one we have is the psychosutural theory, so which was given by the Psycher. So psychosutural theory was given by Psycher, and according to that, according to Psycher, the growth occurs in the sutures. So the sutures are responsible for the craniofacial growth of a person. So the third theory is the Van Limborg theory. So it is not Lamborghini. So Van Limborg's theory, and according to this theory, it is actually a multifactorial theory which combines all the three theories together. So it states that growth is under the control of intrinsic genetic as well as epigenetic, and also the environmental factors are responsible for the growth. And the fourth one is the cartilaginous theory, which was given by James Scott. So according to this theory, the cartilaginous part of the skull are the primary growth centers, with the sutures are when the sutures are the secondary growth center. So he failed the psychosutural theory because psychosutural theory stated that the growth of the craniofacial region is due to the sutures, but cartilaginous theory stated that the growth of the craniofacium, the primary growth center are the cartilage, not the sutures. He said sutures are the secondary growth centers. So according to James Scott, the nasal septal cartilage is the pacemaker is the pacemaker for the growth of the entire nasomaxillary complex. Right. So according to him, the cartilaginous theory stated that the nasal septal cartilage, the nasal septal cartilage is the pacemaker for the growth of entire of the nasomaxillary complex, and it was given by James Scott. All these scientists are also important. So the last one is the functional matrix theory, which was given by Malvin Moss. Functional matrix theory, which was given by Malvin Moss. And the growth of the skeletal component are depend on the functional matrices, or basically we can say that non-skeletal components, or which are the functional components or the functional matrices, are responsible for the skeletal growth. So that means the bone grows via the growth of muscles, via the growth of nerves. So according to the functional metric theory, like how we talked about the growth of the mandible is from Meckel's cartilage, right? So Meckel's cartilage, there is inferior alveolar nerve. So we will be talking about, just suppose this is the Meckel's cartilage, and close to the Meckel's cartilage there is this inferior alveolar nerve which is dividing into mental nerve and also the incisive nerve, right? And here between the both of these nerves there is the primary ossification center for the bone. So because as according to it, the nerve is responsible for the growth of the bone. So it is according to the functional matrix theory, which states that the non-skeletal parameters, the non-skeletal tissue or the functional matrices are largely responsible for the growth of the skeletal component, which is the bone, right? So guys, keeping it short, this finishes the part 1 of the rapid express revision course for the orthodontics, and next lecture we are going to talk about the growth and development. So prenatal, postnatal growth of maxilla and mandible. And if you are looking for the notes of the video, you will find a link in the description box below. So I hope that you will do great in your exam. I wish you all the best for your competitive exam. So guys, take care, keep studying, keep learning. I'll see you soon in the next video.